My name is Nigel Blackwood. I'm a research fellow with the Department of Orthopedic Trauma at the University of Alabama at Birmingham. And this poster is called Presentation and Treatment Differences Between Upper and Lower Extremity Fracture-Related Infections. So fracture-related infections occur when a bone is fractured, surgically fixed, and then becomes infected. And basically, fractures are fixed by realigning displaced bone fragments and then surgically implanting metal hardware such as screws or plates in order to stabilize the bone fragments in their proper position. And then over the next few months, the fragments heal and reunite into one contiguous bone. But with any surgery, incising the skin introduces pathogens and can lead to infection, which occurs in up to 12% of these surgically fixed fractures. Open fractures, where the fracture is exposed to outside air and contamination, as well as unhealthy patients, are risk factors for fracture-related infections. And once infected, patients may need multiple returns to the operating room for irrigation and debridement, bone grafting, or even amputation. The metal implants can be a nidus for infection and may need removal or replacement. And infection can stop or delay bone healing, leading to need for even more surgery and a severe reduction in quality of life due to pain and dysfunction. Because there is a high rate of treatment failure, some patients require upwards of 10 operations to clear the infection, resulting in a huge financial and resource burden for our healthcare system. So there is a lack of consensus on the management of these injuries and fracture-related infections, or on the role of the anatomical location of the infection. So the purpose of this study is to compare the presentation, treatment, and outcomes of upper versus lower extremity fracture-related infections in hopes of developing more specific treatment algorithms to improve therapeutic success. So adult patients with fractures operatively managed at our hospital who developed an infection were retrospectively identified. Data were compared between upper and lower extremity fracture-related infections. 155 patients with fracture-related infections were included. 46 had upper extremity fracture-related infections, and 109 had lower extremity fracture-related infections. Table 1 here shows the characteristics at presentation and diagnosis. At presentation, upper extremity fracture-related infections were less likely to have sinus tracts and purulent drainage compared to lower extremity fracture-related infections, indicating they may have been harder to diagnose initially. Table 2 shows the bacteria species. Upper extremity fracture-related infections were more likely to be infected with C. acnes and less likely to be infected with E. faecalis and group B streptococcus compared to lower extremity fracture-related infections. Table 3 shows the surgical interventions, which were similar between groups. Table 4 shows the number of operations. Here, the total number of operations and the number of debridements were not significantly different between extremities, but the number of reoperations until the infection was cleared was lower in upper extremity fracture-related infections compared to lower extremity infections. Implant failures such as broken plates or screws was more common in upper extremity infections compared to lower extremity infections, and surgical complications were similar between groups. Given these disparities, we believe that further studies should continue to investigate the best practices for treating these infections, given that whether it's upper or lower extremity seems to impact how it behaves and how it's treated. Thank you all for listening.